Well, hello, everybody. I can't see you, but I see about 80 people attended this meeting. It is my pleasure and an honor to talk about topics I care about nowadays. But this is not necessary about whole scan. This is not necessary about Monai. I do Monai. I use Monai extensively. As a matter of fact, I think one of the things I really enjoy using is the combination of Monai and Slicer. I do a lot of inference, both on GPU and the holoscan, but this is not about these two particular items. It's more about providing a big picture as you start the day, and then see how we can converge. Here's an acknowledgement. Most of the research I perform is funded by NIH, and also the slide I present today has an acknowledgement of the people who provided the slides. So instead of listing them here, I like to direct your attention to the credit of the people who actually did the work, and then also for me to talk about it. Let's have a little icebreaker. How can I advance my slide? Oh, there you go. Good. So who is the first Nobel Prize winner in physics? I can't hear it, but I hope I can see the chat window or something. Is something I can see, or okay, I can only see you. Maybe I can just figure out how to do this. But can you answer, yourself? Well, Mike, yeah, there you go. You can do that.
Oh, no, I don't know. I was gonna say, I don't know that people can come off of mute, but if you put an answer, someone did put an answer in chat there. Vikash did.
Yeah. So this is it. This person's name is, I can't see the chat window, but I hope you can, you know what, somehow your face is appearing. Oh, there you go. I see that. Yes, ex-inventor, yes. And in fact, his name is Röntgen. And I'm from Japan, and also I often visit Germany. Often the Department of Radiology is also referred as the Department for Röntgen, because that's the whole medical imaging started. This is the very first X-ray he took with a ring. And then this is what's used today for X-ray fluoroscope and used for image-guided therapy. So question number 2, who won the Nobel Prize in Physiology of Medicine in 1979? Moving on, because I don't see anybody. This is an invention called CT scanner, and then it was funded by EMI. Now, here's a question. Why did EMI involve? Why was it involved? Okay, EMI made a fortune by setting music record for Beatles, and then they actually shifted the funding to support the invention of CT scanner, funded by Dr. Cormack and Dr. Hounsfield. And of course, we're moving on to this one. Who are these people who actually invented a device, medical devices, which was later awarded a Nobel Prize? MRI. Now, these two gentlemen, Dr. Lauterbur and Dr. Mansfield, were the inventor of MRI. Now, yes, there you go. We don't have to. Okay, good. Now, this is a part that I need your attention to put your hand, sync to the react button, and then approach. This year, we got the award given to those 5 people: Hopsfield, Dr. Hinton, Baker, Hassabis, and Jumper. And then we should have a round of applause for ourselves to congratulate that the AI is now subject to the Nobel Prize, and then hope I can see people's reaction. But this is a very good segue to the conversation I'd like to have today about how do we merge and integrate medical imaging with AI. Therefore, that will help, that will have an immediate impact on healthcare. In doing so, I chose a topic called image-guided therapy, which is sort of a specialty I've been working on the last 30 years, and then have a remarkable, the field which has a remarkable progress embracing AI to enhance and solve the problem we've been facing the last 30 years. What is image-guided therapy? Image-guided therapy is use a diagnostic MRI scanner for therapy. This is the paper. This is the picture from the paper published in 2007 from my collaborator Kemal Tankali at the Brigham and Women's Hospital, representing how he used MRI to guide the cryotherapy. The cryotherapy is a therapy to ablate the lead cancer or lesion by using a freezing of the freezing function. And you see this is a 79-year-old woman who has a pain due to lung carcinoma metastasis to a spine. And then you can actually see a tumor metastasize from lung to here. And then here is a vertebrae. And then Dr. Tankali placed the cryotherapy probe to the lesion and ablate the lesion, eventually making it sort of a less, causing less pain to this lady. What was the role of image-guided therapy here? First of all, it still could identify the lesion. It will help you to guide the device to be overlapping with the lesion. Also, which is also you can actually see the effect of the cryotherapy. Therefore, you can confirm that the cryotherapy ablation covers the lesion identified as CT. So there are multiple benefits of using what's called diagnostic scanner for image-guided therapy that involves the imaging of the action as well as imaging of the lesion. Here's another example of another image-guided therapy. In this case, this is a 22-year-old man with a testicular teratoma metastasized to left external obturar muscle. Basically, this gentleman has a metastasized tumor coming here, and then again, because of the difficulty of the surgery, this gentleman chose, and also doctor chose to place the cryotherapy probe, which looks like this with an ice ball performed, and then have a needle coming to the lesion, and then ablation overlapping the lesion, confirming that this area is now treated. So these are the sort of the basic concept of image-guided therapy. So in sort of summarizing the sort of role of image-guided therapy uses the real-time imaging. Again, I like to emphasize this. Diagnostic scan, you send the image archive or PACS, and then later somebody else take a look at it. There's a lot of real-time action-oriented scan happening in image-guided therapies that includes sometimes MRI, CT, and ultrasound, of course, with X-ray. So that actually infers a little bit of a segue to the use of a whole scan or other image processing devices that actually requires the speedy, fast, real-time reaction to the image it's just taken, and so that you can provide the data and information to the physician right away. It actually enables precise targeting of affected areas, as you saw in the video. It is not limited to the example I gave you. It actually includes many surgeries, oncology, and cardiology. So I presented a sort of a one form of image-guided therapy using MRI to guide the cryotherapy. But image-guided therapy can be applied to fluoroscope or catheter intervention or any form of imaging that involves action with diagnostic scan. And of course, it will be applied to the people who cannot receive the treatment because of the complexity of the treatment, or sometimes people choose to do image-guided therapy over traditional surgery because it's supposed to improve accuracy, reduce risks, and enhances sometimes patient outcomes. And there are many articles in different areas where the image-guided therapy sometimes is comparable or is better than traditional treatment. So this is sort of an overview of the image-guided therapy I'd like to talk about today. I'm happy to take any question, and I'm looking at the screen now with chat window, so I'll be able to kind of oh, there you go. I will respond to your question real time. Okay, good. Now, we do this in a research setting at the Brigham and Women's Hospital. This is the Amigo suite, which is the sort of a research OR where we own the space and we actually stuff the room with research-oriented personnel. As you can see, it's a OR, but also we have an option to bring MRI to the OR. Therefore, we can perform MRI scan of the patient as the patient undergoes surgery. Again, action combined with diagnostic scanner. This is actually 3D scanner from Siemens, primarily used for diagnostic scan if you placed it in the traditional radiology department. But in this case, it's actually hang from the suiting so that it moves into the OR. Quite dynamic and innovative idea, but also helps us to perform intraoperative imaging of the patient, showing how much tumor has been taken out of the brain or where the laser probe is leading to the lesion. Therefore, we can ablate the tumor, which is often not operable if they're situated too deep into the brain. Why do I care about this research OR? Because research OR we use is meant to be for use for early feasibility study. Has anybody attending this meeting heard about early feasibility study defined by FDA? And I'm actually looking at the chat window. I'm looking at the reaction thing. It's quite actually challenging to present and talk to myself for 1 hour. So I would appreciate any reaction, including Michael.
Yeah, also, I did hear that people can unmute themselves. So if you want to unmute yourself and mention or say something, you can go ahead and click the unmute and then give Nobu a response back.
Yeah, give some encouragement to keep going for 1 hour.
Yeah.
Well, the early feasibility studies really the niche we Brigham Women's Hospital and then P41 image guided therapy program thrives. It's not meant to be full-blown FDA cleared device to be used after regulatory approval. It is meant to be experimental, but FDA has given us a sort of a landscape and also legal boundary where we can perform this what's called early feasibility study. It is meant to be limited clinical investigation of a device early in development. So you don't have to have a specification set. You don't have to have a V&V set. You can actually still do the agile development as you perform the early feasibility study. So it's so new that you really don't have a specification not set or V&V set. It's meant to be sort of evaluating the device concept. It's meant to get the feedback from physicians, or it's meant to be seeing whether the device can even, impact us, impact the surgery or even impact the way people perform a surgery. So it's sort of a test bed, but also a very well controlled and regulated test bed. In fact, the FDA produced this document called on how to basically, in a nutshell, how to do a first in human feasibility study. And then I am actually, please keep going. This presentation is very rich. Okay, good. And then this is very important aspect for anybody attend this meeting to feel that it's okay to kind of touch upon the clinical application of your devices as much as you perform a device development in a lab. At the Brigham, we work with companies to do this. So this is the sort of a presentation of the work with Canon, who actually came to Brigham and then set up the shop in Cambridge, Massachusetts to work with us and then make a prototype on site in the OR and then perform early feasibility study so that they have an early insight into how their device and technology can be helpful. Well, I'm extending my invitation to the folks attending this meeting to do something similar. You don't have to have a devices, but if you have any algorithm or devices, please come to us. We can perform in a very controlled manner, in a safe manner, try your algorithm so that we can give a feedback to you using our test bed, clinical research test bed for your research purposes. I'm going to move on to talk a little bit about the robotics because I promised in the abstract that I'm going to be talking about image-guided therapy and robotics. But I like to use my own experience and all kind of experience developing what's called snake robot with Dr. Yolanda Colson from MGH with the help of Canon USA. Okay, I'm going to ask the question again. Bronchoscope, what is it? Can you write something on the chat window so that I don't feel lonely and left alone? What is bronchoscope? I'm waiting for the chat window to say something. But where is bronchoscope used? I guess it's easier. There you go. Yes, absolutely. This is beautiful. Thank you, Heriberto. Yes, bronchoscope is used in the lung. Yes. And then this is very tubular devices that actually goes into the lung, like I present on the window in the left. Physician holds a bronchoscope and manipulates this bronchoscope to maneuver and then reach the lesion, often find in the lung, and sometimes on the periphery of the lung, far away from the bronchi. I didn't put the information about it, but in 2017, the the authority has approved the use of the CT scan to screen lung cancer for some people who actually had a history of heavy smoking. And people are flooding to the hospital, taking their CT scan, and then we are finding a lesion. What is lesion? Suspicious of cancer. But often those are not the cancers, those are often inflammation. So people have to go out there and get the tissue to literally confirm the lesion is either cancerous or not. And that number of procedure to take the sample from the lung is increasing. At the same time, the bronchoscope is a very, very highly skilled procedure. And then often people find difficulty maneuvering the tortuous pass up to the lung or lower to the lung. Therefore, they fail to take the tissue in the end and not providing a definitive diagnosis to the patient. A friend of mine from high school actually had the chemotherapy many cycles, but despite the repeated attempt to perform the biopsy, they couldn't get the definitive diagnostics about tissue. Meanwhile, his cancer treatment didn't go well because the drugs they were giving him was not good match the particular tissue he had. And that was that led to very sad ending of losing my friend. And then when I heard about it, I decided to kind of engage in research with Dr. Coulson so that the people like him can be saved in the future. We work with Canon to develop this endoscopic robot that actually works better and perhaps comparable to the physician, even though they may have a lesser experience. This endoscope has interesting aspects. Number one, the endoscope we presented as a conventional endoscope only has a 2 degrees of freedom. In other words, ability to bend. And that's all they have. Well, actually, the physician has the ability to rotate the whole bronchoscope. Therefore, you have a 2 degrees of freedom. I don't know if you can see my finger, but my finger is kind of showing the rotation, bending of the endoscope with rotation. That's all you have to navigate the bronchoscope to the tortuous pass, Instead, this device have a 3 section, 1, 2, 3, and each one of them actually move independent of each other using the actuator placed in the back. There's a linkage, or in other words, the thread connecting this moving parts to the motor. By carefully maneuvering the extent of the motion of the motor, you can actually let it move. Each section move independent of each other. And here's an example. You see a snake coming, the robot coming, and then passing this tortuous pass. I'm going to have to go back a little bit. This is useful approaches to maneuver a tortuous pass like this. This is not that tortuous, but at least it will help the device to conform to the shape of the pass so that it will be easier to maneuver and sometimes easier to maneuver into the tortuous pass. Here we go. And this is another interesting pass. You're going forward, and then you have to turn left. What you have to do in the traditional bronchoscope is maneuver this, that the surgery will perform with manual manipulation. There we go. That's it. Beautiful. Now, this is an amazing device with an outer diameter of 4 millimeter and an inner diameter of 2.1 millimeter. And Canon has put a lot of effort to make this device clinically feasible, and we have been able to perform this with in vivo specimens, in vivo studies. As a matter of fact, we actually investigated if this actually helps. This is sort of, as you can picture, this is a patient. You're looking at the one patient from the top front. You can actually see the right side of the lung. Their airway actually segue into multiple paths, sometimes lower in the lung, or sometimes in the upper lung, and each one of them has a name on it. And then obviously it is much more difficult to place the lung by the snake robot and then go upwards and then make a turn. Occasionally, people are tasked to perform the placement of the snake up to 5 generations. 5th generation of the airways, and that's often considered more peripheral. And then there has been a report of aiming at the 6th, 7th, 8th branches. Every time you come to the branching point, you need to use a motion like this to conform the device to fit to the bronchoscope. Therefore, you can perform the bronchoscope well. Now, this is where things becomes very interesting and becomes more AI related. Now, what happened is this device, it has a commercial, it's commercially available elsewhere. But what happened is often physicians are tasked to use a special interface. In my case, or in some companies, some other industries examples, people are asked to use gamepad. So this is Franklin King from my research lab. And then he claims he has an extensive research experience on gamepad in his personal life. And then he's using this gamepad to do an advancement of the snake. And there's an interface here showing what kind of command he's giving to the snake robot. Snake robot is being pushed to advance by one button. I don't know, that is yellow A, B. I don't know exactly what they call. But also he's tasked to give a sort of overall turning direction, and then using the one of the gamepad. And believe it or not, he, being a developer and also extensive experience with an extensive experience of gamepad, performed this best. Whereas some of the physicians with less experience with a gamepad didn't do well. So we thought we can do better to accommodate the new users or sort of people with a relatively well, I don't know how much of this gamepad is now available in the Xbox and that kind of stuff, but you know, I don't. So honestly, don't think it's not right for the physician to rely on the skill to use gamepad. Now here's what we worked on. I hope I can show the sound, but I don't know if that's possible. But I'm going to show you what's going on. So Frankie is now not using the gamepad at all, and he's giving the verbal command or a voice command to let the device to advance and also find the airway, and also per his command, steer the robot to the airway he command to. Okay, so this is the interesting part of the presentation where holoscan, you know, maybe is useful. So I'm going to give you a little, because most of the audience, I believe, is an engineer, I'm going to actually give you an engineering breakdown of what's going on. We use the same interface command, like a right, left, move, forward, and back. What's different is we actually take, is a perforation? Yes, that's a good question. I'm going to answer that question. We actually take the native bronchoscope images, in this case, black and white, as it is. We feed it to our model. The model the model actually produces what's called depth map. The depth map, from the depth map, we actually identify airways. In this case, it's erroneously identified as one airway, even though there's a two airway. I believe it's going to recognize a two airway. Here you go. Here you go. Look at this. I like this. This was impromptu spontaneous, but I think it did a good job. You see, we got the depth map. My algorithm is detecting this as a one single airway. As it advances, boom, there you go. You got the two airways. Now, next task for the Frankie is to tell the device, because it's now aiming this airway. If you want to switch this airway over this airway, Frankie can tell a voice command and then shift the aiming target to this airway. I don't know if he's doing that. Let me see. If the green thinks, oh, you continue to the same airway. Okay, well, that's fine. Sometimes you actually command the device to move to the different airways, and that's where the voice command is useful. Okay, now how do we get the depth map? Well, we actually came across with an interesting method using the CGAN to produce the depth map from the raw native bronchoscopy images, and we published it and then placed the data set. Actually, I work with the Monite team to sort of share this with a community. It's placed it in the Harvard Dataverse. So what happened is we actually made a model that actually processes the raw data set and then produces the depth map. And from then on, we have a particular algorithm to detect the airway, and then also particular algorithm to aim the center of the airway so that the device cannot touch the airway. There's a question whether this population happens or not. Well, that's a very good question. First of all, one of the features of this robotic device is meant to be soft. Therefore, physically, it's meant to be safe. And that's exactly what the Canon team did to make it clinically feasible. In fact, the paper, actually, maybe I shouldn't. The paper I published in the past shows that the use of the snake robot actually reduces the force incurred to the airway wall. So indicating that it actually helps you to maneuver easily and more easily than the traditional bronchoscope, where there's a lot of a push and then a pull force involved to the advanced bronchoscope. The second thing, the beauty of this robotic device, as you can see, is it actually trying to aim the middle of the airway. So the image processing and then depth map helps you not to push your robotic device to the wall. Did I say not? Yeah, not to the wall, but rather keep it in the center. So that's the sort of a magic of the depth map. Well, the Michael invited us. Actually, Mark Edgar. I don't know if he's on the focal or not. And Michael Zephyr invited us to join their Monai workshop in 2023. Was it 2023, Michael? Yeah, it was. Yeah, I only remember it was Vancouver. Yeah, it was Vancouver. It was cool. It was Vancouver, and then we had a good, fun half day, actually whole day to do this. And I think we brought this AGS to the site, I think, or not. If not, I'm sorry. Maybe I used it first.
Yeah, I think you guys did. Yeah.
Yeah, and then we actually this is a setup almost identical to the thing I did. So actually, I took the Phantom. Actually, this is not just a Phantom. This is a patient-drive Phantom. Okay, so it's a Phantom of the representative of the sick patient. And actually, we brought a simple camera to be placed, and then actually feed it to the Clara AGX and perform the depth map computation on the spot. I think inference time at this point was about 12 milliseconds. Yeah, look at this. This is the input image. This is the output images. And we still use it in my lab to do research. And then this is hugely helpful for us to advance research to the stage that we can start using it in the real-time setting, enabling us to kind of explore autonomy. Did that make sense? I think my English was not too complex. The real-time inference help us to accelerate the research to do a real-time autonomous control. So that was quite a good work. Clara, I don't think you guys have a Clara AGX anymore because you actually advanced the devices to medical grade. But for us to do a feasibility study, Clara AGX or whole scan, either one of them is suffice, and then we could now tell that the autonomy helps, particularly the junior, inexperienced physician to perform bronchoscopy, which is interesting aspect. 11:48. I have about 25 slides left, 19 slides left. How am I doing? Do I have any question from the audience?
I see one question. Does it cover taking biopsies?
Yeah. So we have a working channel in the middle of the snake robot, and we can place the forceps to grab the tissue or perform the rinsing of the tissue so that we can take the another form of biopsy. It's really meant to be clinically useful. Okay.
Yeah, and then you have about 20 minutes or so.
Okay, good. So I like to provide a topic of the conversation for you. So I'm going to just skip it. Now, I believe most of us are engineers, and then none of us was not. Oops, I have a hiccup going on my laptop, desktop. So, I mean, Speaks has been doing a great job to put the autonomy into robotics, but nothing excites me than this one, showing that the booster is caught by what's called chopstick. We call this chopsticks to catch this on the ground. And there's a lot of, I believe a lot of autonomy is involved. And I think that's where we are talking about today. Autonomy has been year emerging as a concept in robotics image therapy, and then it's kind of driving our curiosity to think whether that's even feasible in surgical robotics and image therapy. And then I have a bit of a conversation about it today, and then kind of cover it. In 2017, the team of scientists from Children's National, Dr. Kim and Axel Klieger presented the paper. came up with an amazing paper, sensational paper, talking about the autonomous suturing of the inner anastomosis. So this is kind of a combination of many enabling technology, tooth detection, the tissue detection, all of this put together to help the physician to perform not the physician, robotic device to perform automatic suturing. I think I'm going to have to forward it to you. Here we go. Look at this. So this is the physician working with the robot to perform a suturing. This actually came out of nowhere, and then we got surprised. We were surprised to see this, and then actually that led to many sensational discussion about a lot of news article whether autonomy in robotics is coming. And a year later, I got the invitation. I got the phone call from the folks at the Science Robotics and Guangzhou Yan to come to this place in Washington, D.C. to talk about the future of robotics. And that was 2017. And this is one of the most cited paper in this field because it actually talks about the regulatory, ethical, legal considerations of autonomy in surgical robotics. Interestingly, it is still the major topic of conversation in autonomy rather than technical discussion about autonomy. So I'm very amazed at how people care about this social aspect of autonomy, but at the same time, I was very fortunate to be part of this paper and then talk about it. And then these are sort of the things we kind of laid out to kind of tell the people that what kind of autonomy is coming. This gentleman, Dr. Daimler, who was at the science technology guru at the White House, I think it was an Obama administration, maybe not, told us that you need to prepare the society to embrace the autonomy by giving them a roadmap from nothing to full autonomy, so that the people start to see it as a progressive manner instead of sudden appearance of a robot performing everything. That will scare the people up. So people basically we are tasked to put together this progressive advancement of the autonomy from 0 to 5. I'm not going to go into detail. And then very recently, which is almost like a couple of months ago, somebody published this paper talking about what has been improved in FDA, approved FDA to perform autonomy. And that's very interesting. This is a sort of a summary of what has been approved. I'm not going to go into detail, but the level 1 is simply robotic assistance like a Da Vinci. That actually covers almost 40 approvals. And only 1 or 2 devices has been approved with a conditional autonomy where you give a command to the robot and robot perform the surgery as the physician hold the stop button and then stop it when the robot start to misbehave. Interestingly, look at this. The device with the highest autonomy was approved very early in the history of medical robotics, but stays there as the only devices. Is it interesting that we have not had the new devices level 3 or even level 2 in the last few years? Even so, we've been very excited about the autonomy. So not much has been done in autonomy. And then I can come up with 200 reasons why there have not been, but I think one of the reasons is about the enabling technology not sufficient. So what are those devices? Actually, that's one in orthopedic surgery. Devices approved for orthopedic surgery is called the Robotic. That was originally approved for performing osteotomy, and then was passed to the different company from Korea to be cleared for approval from FDA in 2017. So that's the device. I think I can find it here. Where is it? Enhance. Oh yeah, this one. This one, Think Surgical. This is a device for orthopedic surgery. And then other devices are pretty much limited in scope and then device than earlier. And then all of them are 510K. I want you to pay attention here. I'm going to talk about it in the next slide, but actually, here's the next slide. FDA actually have a list of artificial intelligence and machine learning enabled medical devices. And then if you can click, you can't click this. If you Google this, you can reach to these devices. And as of today, August 2024, or this morning, 950 AI ML enhanced medical devices has been approved by FDA for marketing. and clearance for marketing. And you can actually see all 510K, all these approval letters listed in the website. I would suggest you go there and then see what's in the letter from the FDA. Interestingly, all of these devices, what's AI, the only one device is listed in the FDA database for AI-enabled autonomy, and that's from this company. And then also, this is also marketed as an AI-enabled devices, but other devices are not marketed as an AI-driven. So the new era of AI-driven autonomy or smart, intelligent medical devices has not been here yet, or I would say it's emerging, as you can hear from the rest of the folks here. We are working on it. For instance, for the needle insertion for prostate, we often find that this blue ideal path to the cancer cannot be reached, because if you place the needle a little off the ideal target, it tend to drift, continue to the different part of the prostate, not helping the physician to get the tissue from the intended target. But sometimes using the automatic steering, using the image detection, needle detection, and then also feedback control will help you to guide the needle toward the target, even though it started out off the target, toward the target. So this is one of the examples we have. We also have an intra-procedure segmentation of the cryotherapy probe, which eventually makes the cryoablative lesion. But we can actually proactively tell, okay, given this arrangement of the probes, you will produce a cryotherapy lesion like this, but don't start it yet, because you may not be able to fully ablate the lesion and kill the cancer. If you have a sort of a you have a shortage or missing lesion that may not kill the cancer, you better place new probe or place the next probe in different position. This way you can help the physician to perform this. This is the intraoperative, the segmentation, again, using the set of the AI tools we develop in the lab. We are not sure how autonomy helps yet. And that's kind of a dangerous notion here. It's still driven by engineers' curiosity, and we haven't really having a consensus how it helps. We often find the learning curve, maybe the area we may impact, the procedure using AI and autonomy. But this is one of the sort of things you can tell from the paper published in 2021. This actually indicates the improvement and time of the bronchoscopic navigation, bronchoscope performing by physician when they get trained. Okay, let's take a moment to take a look at this graph. When you give a new devices to the physician to learn to use it, this is the first case, zeroth case, and then this is the sixth case. As you learn to use it more often, the physician takes more time. Again, this is hard to tell because I can't really tell what the QCSM is. They take more time. In other words, less performance in terms of time to perform it, but it gets faster, and then actually, you know what? I'm sorry. It gets faster, but eventually it gets slower and faster again. Okay, as you learn to use it, they became faster to use it, slower to use it, and go back to the original state. At the same time, they improve the performance. So this is interesting because the physician try to use it in the 11th case. I think 11th case try to use it quicker, but it actually becomes trying to become confident in making cognitive decisions in maneuvering devices in different stages. So actually, as they kind of carefully analyze their cognitive perception, decision, and action process, they actually takes more time and eventually go slower. I believe, and we believe, that providing an autonomy will help them to get to this, the proficiency, but without the compromise in the time. And then the reason is because during the time that you learn to use it for 47 to 80 cases, the patients are at risk. The patients are used as a sort of a training material for them to learn to use it. This is a sort of a this is a sort of a style of the training in the medicine for a long time. They actually learn by using it. So I think the autonomy will help the physician to do this better by quicker quicker and less risk to the patient, eventually making the devices more useful for them, but at the same time make it available for the people getting a training at the under-resourced population areas or settings. What's going on about the research and development and autonomy? I have to say, this is a paper, another paper published very recently. I have to say that it's very disappointing that we are still stuck in enabling technology. We are still trying to develop tooth tracking. We are still trying to develop the tissue interaction sensing. We have not done much to make it as a final product. We are trying to recognize a gesture, but we really haven't really done much to do advance that gesture to help the needle insertion, not dying. If you look at it, the state of the research is still stuck in the preclinical. Not much has been advanced to the sort of in vivo stage where physicians can at least comfortably use it in animal studies. So we are still stuck in the individual technology that can be used in the future as an integrated system. But we will see that and coming and emerging in upcoming 5 to 10 years. And I think that's where I will kind of start to kind of think about my next career, because once somebody start to do the commercialization, we're going to have to find the new challenges. Anyway, so I'm trying to conclude my talk to fit in the time. My talk cover some of the history of imaging therapy, history all the way back to 1901 for the first Nobel Prize, and then we presented that the imaging therapy is really using diagnostic imaging for therapy, with a lot of benefit, right? Like confirming where the lesions are, where the tooth is going, how much treatment have done. It's a very dynamic, real-time environment where AI has to be delivered on the fly, and that's where HoloScan is useful. We have a sort of our beauty and then value of the first human study, and then we provide Amigo as a platform for everybody to come in and try their own new technology with us being involved. And that's really open science and collaboration, fertilizing that advancement. That's really kind of a synergistic to the concept of Monai, where sharing will advance our innovation, the speed of innovation. I used autonomy as a driver for AI. And I'm not saying that's the only driver for AI, or at the same time, AI is currently used mostly as a key enabling technology for autonomy. I don't know which one is which way I should talk about it, but I think autonomy is a kind of a clear, tangible goal we can aim at, because there's a benefit of a learning curve, there's a benefit of helping the lower resource countries, lower resource setting to use the cutting edge technology, and then we also see regulatory landscape is kind of embracing it. Not at the same time, we have to pay attention to what's happening around us, which eventually help us to learn to adopt the autonomy and then AI into medical device technology. So I hope I covered the basic topic that may give you a foundation for further discussion for the rest of the day in this exciting Monai days. Thank you so much, and this is it for my talk.